Ladies and gentlemen, dear colleagues, first of all, I would like to thank the organizers for the invitation. It's really an honor for me to be part of this extraordinary meeting. So my topic, the use of soft tissue substitute in periodontal plastic surgery. And there's no doubt that periodontal plastic surgery plays today an important role in contemporary periodontology. And why is it? We have a lot of these recession defects in daily practice, so this is what you see in your office every day. We know that the prevalence of these gingival recession defects is among 50 to 100%, affecting young patients, old patients, patients with a good level of oral hygiene, but also with poor oral hygiene. We know that most of these recession defects are quite narrow in the vertical extension, so the real deep single recession defects we don't see so often, but we know that all teeth can be affected and that we have a lot of Miller class 1 and 2 recession defects, much more than classes 3 and 4. The first step should always be to ask, okay, what actually caused this recession defect? So in daily practice, most of the defects you will see will be associated with a traumatic toothbrushing technique and will be located at the buccal aspect of the teeth. But you will also see recession defects as a consequence of inflammatory periodontal disease, which are going to be more circular. And you should always take care and look what kind of predisposing or precipitating factors are involved. So is there some facially displacement of the roots? Is there some orthodontic treatment involved? What about frenal attachment? And do I have iatrogenic factors involved? So usually the patients come to your office complaining about aesthetic or root hypersensitivity. Meanwhile, we have also some self-screening tools, online-based, so the patients can look, okay, do I actually have gum recession? What kind of biotype do I have? Do I have inflammation? And then he gets some gum recession susceptibility score, and he's advised to see his dentist or periodontist. So this is some kind of improvement for our patients. When it comes to the different surgical techniques, you see here, according to Bouchard, we have the group of the pedicle flaps. Mostly we will use a coronally advanced flap, but we might also go for laterally positioned flap, a double papilla flap or a semilunar flap. And then we have the more modern techniques like the envelope flap or the tunneling techniques. Then we have the group of the free soft tissue grafts, including the free gingival graft, which was described as a one-stage procedure or also as a two-stage procedure according to Benny Moulin. Then we have the group of the connective tissue grafts combined with the classic pedicle flaps or also with the envelope or the tunnel technique. And we have the group of the additive treatments, which would include the use of root surface modifiers like EDTA, tetracycline, citric acid, the use of resorbable, non-resorbable membranes, emdogain, the group of acellular dermal matrices of human or porcine origin, and we have PRP, PRF, and now we have the possibility to combine these additive treatments with the soft tissue grafts and with some group of the pedicle flaps. So a lot of combination possibilities. So in general, the choice for a specific surgical technique all usually depends on the depth of the recession and also on the depth of the vestibulum. So first to see, okay, how actually deep is this recession? Is this a case for a one-stage procedure or a two-stage procedure? What kind of gingival biotype do I have? So is it something to go for full thickness or split thickness? And how is the amount of keratinized tissue left in the area of the recession defect to see, okay, can I go for coronally advancement or laterally advancement of the flap? So if I want to perform a coronally advanced flap, I should have at least 1 millimeter of keratinized tissue apical to my recession defect. In moderate recessions, if I have a deep recession defect, I should have at least 2 millimeters of keratinized tissue left apical from the defect to go for coronally advancement. So let's go chronologically through the development of these techniques. And we will start with the free gingival grafts. So I would say the area of the 70s and the early 80s, this was like the time of the free gingival grafts. So based on the work from Lang and Lowe, it was considered that we need at least 2 millimeters of keratinized tissue. 1 millimeter should be attached to maintain periodontal health. So in this era, a lot of free gingival grafts were performed like a preventive measure, and you can see here the outcome, the baseline situation. Oh, I'm sorry for this. The baseline situation at the left side, and on the right side you see a nice amount of keratinized tissue. It is attached, but you see also from an aesthetic point of view that it's not optimal. So a white zone of keratinized attached tissue, but if you take a look at the color, the integration into the surrounding tissue, the surface structure, it's not really perfect from an aesthetic point of view. And that's what we know today when it comes to aesthetic root coverage procedure. We know that the colorimetric integration is the most important parameter, followed by the texture match, the volume match. You want to have also a nice gingival contour. You don't want to have any scars. And so from this point of view, the free gingival grafts, so the non-submerged grafts, are not really the first choice when it comes to aesthetic coverage of exposed root surfaces. So you see on the upper right picture this motorway of keratinized tissue. Yes, a lot of keratinized tissue. It is attached, but from an aesthetic point of view, it's not really pleasant for our patients. So the next step was the introduction of the connective tissue graft in the mid of the 80s, combined with the pedicle flap, and here we have the big advantage of the double supply regarding the vascularization. So you have the vascularization from the periodontal and the supraperiosteal plexus and from the inner side of the flap, and you can see here the combination of the connective tissue graft with a laterally moved and coronally advanced flap, and you see the outcome 8 weeks post-operative, and now you see the big difference with the submerged graft in comparison to the free gingival grafts. So it's not only the coverage effect, you have the thickening effect, but you see also when it comes to the aesthetic parameters like colorimetric integration, integration into the surrounding tissue, the texture, it is much preferable in comparison to the free gingival grafts. The next step, also beginning from the mid of the 80s, was the evolution of the minimal invasive surgical techniques, starting with the envelope technique described by Professor Detzke in 1985. So the first technique which avoided it was like the first minimal invasive procedure, no vertical incisions, and you see his supraperiosteal envelope preparation, harvesting of the connective tissue graft, insertion into this envelope. 3 parts were lying within this envelope, 1 part was exposed. You see the exposed part became keratinized, and you see the outcome 10 weeks post-operative, with again a nice coverage effect and also thickening of the tissue, and also from an aesthetic point of view satisfying. So based on these envelope techniques, the next step was the invention of the tunnel technique, which has now been modified a couple of times. So you see here multiple recessions in the second quadrant. The whole area is tunneled. the CTG is grafted from the palatal side, insertion into the tunnel, and you see the clinical situation 6 months post-operative. Again, it's not only the coverage of the exposed root surface, it's also the thickening effect, and also the aesthetic parameters are much better in comparison to the free gingival grafts. So you see, this is definitely the benefit when using the autogenous connective tissue grafts. And so this is what, let's say, has become like a standard when it comes to the treatment of multiple gingival recession, that we use some kind of tunneling approach. Also, like in this case, multiple recessions in the second quadrant, the whole area was tunneled, the interdental tissue also mobilized. The connective tissue graft was inserted into the tunnel, and you see the clinical outcome 1 year post-operative. And also here you have the coverage effect, thickening effect, and also nice integration into the surrounding tissue. So definitely big development in comparison to the use of the free gingival grafts. Another benefit of the autogenous connective tissue grafts is visible here. So why I'm showing you this case is not because it was very good, but you can clearly see that at the time of suturing, the graft was exposed at least 2 to 3 millimeters. You can see the healing and the outcome 3 months post-operative. So in the area where the connective tissue graft was exposed, you have a nice amount of keratinization. But on the other hand, you can see also the negative side, because from a colorimetric point of view, it's not perfect. So you have here the characteristics of the palate, and you see that the color actually is not matching. So yes, you can leave the connective tissue graft exposed to gain some keratinization. On the other side, if you want to have a perfect aesthetic outcome, you should fully cover your graft. So let's summarize the advantages of the autogenous connective tissue grafts. It's the type of healing. So we said that we have the double supply of the connective tissue graft, and this was shown by Raul Cafez's group in this animal model, and they showed actually the fully submerged connective tissue graft is completely vascularized after 14 days. So we have this double supply from the periodontal and the supraperiosteal plexus, and from the inner side of the flap. This makes this type of healing very fast and stable. And we have also data which showed that we can leave the connective tissue graft exposed up to 2 millimeters to gain some keratinized tissue. On the other hand, if you want to achieve complete root coverage, you should take care that the graft is completely covered. So when looking at the data for the autogenous grafts, we can definitely say when it comes to aesthetic root coverage procedures, the autogenous connective tissue graft is the gold standard. So all systematic reviews and meta-analysis do support this. And if you look at the mean root coverage following a coronally advanced flap with connective tissue grafts, it is ranging between 64 to 90, 70%, and the complete root coverage is between 18 and 80%. But there's no doubt the autogenous graft is the gold standard in aesthetic root coverage procedures today. However, we have also the other side of the medal, and this is the patient morbidity associated with the harvesting of the connective tissue. So you can see here the different harvesting techniques. Most of us use the single incision technique according to Hützler and Wenger. Some of us like to use the deepithelialized gingival grafts. We use one side of the palate, both sides of the palate. Some are harvesting with an epithelial collar, the other ones without. Some are using the tuberosity area. But one might also experience some complications. And it is always claimed that the complication rate is low. That's true, but from time to time you can see here one might experience some severe bleedings, like here on the left side. And sometimes you might also experience necrosis of the flap, infection involvement of the bone in the healing period. And you can see here 3 weeks post-operative, the palate is still not completely closed. So yes, the complication rate is quite lower, but you see from time to time, you might also experience severe complications. The other thing is the limited availability. So we got used to see very nice cases regarding the use of the autogenous grafts. And you can see here a nice paper from Sonic and Huang. And you see the multiple gingival recessions in the maxilla and the mandible. And you see the final outcome in the lower picture. Very nice clinical outcome, but you can see also the treatment plan. So it was more than 3 years of treating, because one surgery meant 2 sides of the palate involvement. Then there was a pause of 9 to 12 months, and then the next stage again, both sides of the palate. So you have always this problem of limited availability, and you see for 4 quadrants, sometimes you need 2, 3, 4 years until you actually solved the complete case. So here is also a nice case series from Griffin, looking actually at the complication associated with the harvesting of the autogenous grafts. And you can see here more than 250 grafts in more than 220 patients. And actually they reported in 30% of the subjects that there was some moderate or severe pain. Also more than 30% of the subjects reported moderate to severe swelling. In more than 1% there was some bleeding, and more than 7% of the subjects reported moderate to severe discomfort after 1 week. So you see, okay, the complication rate is quite low, but is it comfortable for our patients? Not really. So you see, okay, there is pain and also there is swelling associated with the harvesting of the autogenous grafts. So already at the last EFP workshop, it was this group 3 at the 10th EFP workshop, they concluded that the limited amount of the autogenous donor tissue and the increased patient morbidity are substantial disadvantages of the autogenous connective tissue grafts. For this reason, the search for suitable soft tissue substitutes is currently in the center of interest of scientists and manufacturers. So we are looking for some possible alternatives to the autogenous grafts. And the question is, okay, what are these alternatives? So can we go for these soft tissue substitutes in the future? Do we still need these autogenous grafts? And if you can take a look at this very new decision tree for the treatment of gingival recession, it's the newest one from Richardson and co-workers, and this is the first decision tree based on the availability of the autogenous donor tissue at the palate. So it states when you have sufficient donor tissue, yes, still the first choice is the autogenous connective tissue graft, but you see you have some alternatives. You see here the Emdogain, the acellular dermal matrices of human origin and porcine origin, and you see now here if the patient doesn't want to have the harvesting of the connective tissue grafts, you have some alternatives. And also here, if he has no connective tissue at all at the palatal donor site, you have here acellular dermal matrix grafts, you have Emdogain, and you have the possibility of combining these things together. So you see the things are slightly changing. And when we are talking about the soft tissue substitutes, for sure, the first one which was available was the one of human origin, the alloderm, which is now about 20 years on the market, and the principle was to harvest some human dermis to remove the epidermis and the subcutis. The dermis was prepared to get an avascular and acellular 3-dimensional collagen construct, which was used as substitute for the autogenous grafts. If we summarize the evidence for the alloderm, you can see quite some heterogeneous data. You see here the conclusion from the systematic review from Tatakis and co-workers, which stated that there is a strong evidence to support the use of alloderm in conjunction with the coronally advanced flap as an alternative to the autogenous donor tissues. On the other side, the systematic review from Francesco Caido and co-workers actually concluded that studies adding alloderm under coronally advanced flap showed a large heterogeneity and reported benefits are not significant compared to with the coronally advanced flap alone. So you see the data are somehow heterogeneous. You see it seems to be that these kind of procedures are technique sensitive and a lot of different data available on this. So since these human materials are not legalized at the European market, we are focusing more and more on the acellular dermal matrix graft of porcine origin, and one of them is the Macadam from botiss biomaterials. The principle is actually the same. You harvest some dermis, but it's of porcine origin. You get rid of the epidermis, the subcutis, you prepare the dermis, and you get also a vascular acellular three-dimensional collagen matrix, which is pretty similar to the human ones, although perhaps a little bit denser regarding the structure, but otherwise very similar. So what are the benefits of the Macadam matrix? From my point of view, you have a structurally intact connective tissue matrix. It is acellular, it is non-immunogenic. You have a short hydration period. You can rehydrate this matrix in autogenous blood or saline solution. You can trim it and cut it after rehydration. So you can nicely adapt it to the recipient side, which is definitely a benefit. You can insert it into a tunnel, you can suture it, so you have enough time to work with this material, and you can see the newest generation has a thickness which is ranging between 1.2 to 1.7 millimeters. This is actually the optimum, also the thickness which is today actually propagated for the autogenous grafts. So here are the different indications I see for the use of the Macadam matrix. Most experience I gained by using it for recession coverage procedures, but one might also think about using it as a free gingival graft substitute in an open healing manner, as a substitute for membrane within GBR procedures, thickening of tissues buccally around the implants, pre-prosthetic soft tissue rich augmentation, and also as a substitute for an autogenous punch when doing socket seal procedures. So when talking about the clinical use of these matrices, there are several factors influencing the clinical outcome when working with these matrices. And in my point of view, the most important ones are which you have to consider actually how is the pre-surgical tissue quantity and quality, because you have to be aware that these matrices, they are avascular, acellular, so they have to get the nutrition from the overlying flap, which means you need sufficient vascularization of the overlying flap, which means you have to take care and look at the amount of tissue pre-operatively. Also the question, do I have a band of keratinized and or attached tissue which I can use for suturing, because the matrix has to be fully covered and should also heal fully covered. So these are things you have to consider prior to your surgery. And you can see here nicely what it means fully covered. You see here at the moment of suturing, this avascular cellular matrix is exposed about 1 millimeter. You see the healing 2 weeks post-op, 4 weeks post-op, and 3 months post-operative. And you see actually that the exposed part has completely get lost. So it's not that you have this forgiving effect that you are used to have when using the autogenous grafts. Okay, when the autogenous graft is a little bit exposed, you will gain some keratinized tissue. When using this dermal matrices, you should fully cover the matrix, otherwise the exposed part will get lost. You see here a couple of cases, a single gingival recession defect with a wide cleft due to a traumatic flossing technique. You see the preparation, full split thickness flap, the rehydrated and prepared Macadam Matrix sutured to the recipient side. The matrix is fully covered, and you see the outcome at 12 weeks post-operative. You see the coverage effect, you see the thickening effect, and also now from an aesthetic point of view, I think the colorimetric integration is okay, and also the integration into the surrounding tissue. Also here, the multiple recessions, so you can use all the different techniques you know, just as long as you have sufficient vascularization of the overlying flap. You can also go for a modified coronally advanced flap, like in this case. You see the multiple recession with the center of rotation at the canine region. Again, the rehydrated and adapted Macadam Matrix. You see the healing at 3 months post-operative, and the final outcome 1.5 years post-operative in comparison to the baseline situation. And again, it's the coverage which is good. You have a nice thickening of the marginal tissue, and overall the aesthetic parameters are quite good, and we achieve this without using autogenous grafts. Also, you might go and combine your Macadam Matrix with a tunneling approach. As you can see here, the first part was prepared in a full thickness approach, then over the mucogingival junction in a split thickness manner. The matrix was rehydrated, inserted into the tunnel, and you see on the right side the final outcome 3 months post-operative. So if we summarize the available data on the porcine-derived collagen matrices, then we can see, first of all, that these collagen-based matrices demonstrate better clinical outcomes in comparison to the coronally advanced flap alone. So regarding mean recession coverage, recession reduction, gain in keratinized tissue, we gain better results than when using the coronally advanced flap alone. Also very important, there seems to be no difference in patients' aesthetic satisfaction between this xenogenic collagen matrices and the autogenous tissues. And what we also see in all studies, that we have a reduced post-operative morbidity and a shortening operating time associated with the use of these collagen matrices. So all data are showing really reduced post-operative morbidity and significant shortened operation time. The data on the Macadam Matrix, we have one case series showing mean root coverage of more than 70% in Miller classes 1, 2, 3, and also data from one randomized controlled clinical trial showing mean root coverage of more than 90% in Miller classes 1 and 2, so pretty good data. But we also see overall, yes, these matrices are better than the coronally advanced flap alone, but not as good as the connective tissue graft. And Cambadone and Tatake stated in their last review, still the autogenous grafts are better about 9% than the collagen matrices with coronally advanced flap. So the question is, how can we improve the clinical outcomes to come as close as possible to the autogenous grafts? And one possibility is the combination with Emdogain. You know, Emdogain has regenerating capabilities, angiogenic capabilities, also antibacterial, anti-inflammatory effects. So it makes sense to combine this avascular acellular matrix with the Emdogain. First, to use the regenerative potential at the root surface, but also to improve the wound healing and the angiogenic effect. And we have this one work from Shidakata and co-workers showing that this combination therapy actually promoted periodontal regeneration and increased also soft tissue thickness in comparison to usage of the matrix alone. So here a couple of cases of this combination. You see here following orthodontic therapy, multiple recessions in the lower jaw, the preparation, full split thickness, Emdogain application to the root surface, then the matrix suture to the recipient site, another layer of Emdogain on top of it. You see the healing 12 weeks post-operative in comparison to the baseline situation. So yes, you can also achieve nice results in the mandible just as long as the matrix is fully covered. Another case, multiple recessions in the second quadrant. Here a modified coronally advanced flap, the preparation, full split thickness, Emdogain application to the root surface, the matrix suture to the recipient site. You see the closure of the surgical site, the early healing at 4 weeks. You see the healing at 8 weeks, 10 weeks, 3 months and 9 months post-operative, and the final clinical outcome 2 years post-operative in comparison to the baseline situation. And also here, the possibility to combine it with a tunneling approach. Also here, the application of the Emdogain to the root surface, then the matrix, another layer of Emdogain on top of it. And you see also here the outcome 3 months post-op in comparison to the baseline situation. Also here in the maxilla, you can use this VISTA approach. We tunneled here everything from the frenectomy performed. Again, the Emdogain application, insertion of the Macadam Matrix through this vestibular incision, and you see the outcome at 3 months in comparison to the baseline situation. Also here, you see you have the possibility of combining your matrix with all the available surgical techniques. So the focus is to maintain the vascularity of the overlying flapper. So you see, when working with these matrices, there's a learning curve, definitely. It's technique sensitive, but when I compare the benefits to the disadvantages, I see much more advantages than disadvantages. You see there's no second surgical site, less post-operative complications, the surgery time is reduced, you have unlimited availability, so you can go for one operation or 2 operations to cover all 4 quadrants in a time, and it's definitely a patient-friendly approach. Possible disadvantages are, yes, you don't have the forgiving effect, so it's technique sensitive, and you have to charge something for the material. So let me come to my main conclusions. Today, these porcine-derived collagen matrices for sure provide a safe and reliable option to the autogenous connective tissue grafts for root coverage procedures. We saw that the use of these collagen matrices is associated with a significant reduction in post-operative morbidity and a shortened operation time. It is important to completely cover these matrices, since an early exposure can lead to graft failure. So it's definitely a technique-sensitive procedure. We also saw that the clinical outcomes are pretty close to the autogenous grafts, and by adding Emdogain, we may further improve the clinical outcomes of the porcine-derived collagen matrices to come as close as possible to the results we can obtain with the autogenous grafts. So thank you very much for your attention, and please feel free to ask me any questions. Thank you.